Now, the next section is about augmented reality to virtual reality, from patient care to surgical simulation. So augmented reality, virtual surgical planning, 3D printing, bioprinting, they're disruptive technologies that are changing surgery, particularly in head and neck surgery and facial reconstruction. This session will explore how those technologies can change patient education, surgeon training, patient outcomes, and reduce the side effects of reconstructive surgery. So we're going to hear from Associate Professor Payal Mukherjee, an adult and paediatric ENT surgeon subspecialising in hearing and balance disorders. As the ENT research lead of the RPA Institute of Academic Surgery, she's been awarded many research grants. She's doing a PhD on innovative technologies in ENT. She's got a great interest in advocating for surgical research and building respect and gender equity in surgery and academia. We'll also hear from some of her colleagues that she'll introduce: Professor Jonathan Clark, Kai Cheng, Hamish McDougall, Elodie Chiravano, and Professor Gordon Wallace. But first, please make Payal very welcome.
We changed.
Oh, you tricked me. I thought you were... Sorry.
Morning. You've all just heard a very inspirational talk about the future of healthcare. I'd like to bring a focus now on healthcare of the present day, because it's really the innovations of today that shapes and influences the future of healthcare tomorrow. And that's more so because at this very moment, at our very fingertips, we have access to tools and technologies that, if used well, has the power to take Australian health and Australian industry and put it at the absolute forefront of world health innovation on a global stage. I'm sure you'll all agree that each day we're pushing our medical marvels that little bit much further and taking on more and more complex cases with less and less invasive means. However, at the same time, we're facing a population that's not only increasing in size, it's also increasing in age, and growth must be sustainable. In this space, intelligent use of smart technologies such as augmented reality, virtual reality, and 3D printing has the power to really transform healthcare, because not only does it help us do things better and faster, it also helps us do things incredibly cheaper. This technology is not it's not novel. It's around everywhere. In fact, my first exposure to this technology was through my daughter's toys, children's toys, and it made me think: what if we take these digital assets and apply them in healthcare? What if we take these technologies and use them in pre-surgical planning so we can improve our patients' outcomes? What if we take these technologies and use them to educate our patients so they're more motivated patients, they understand better about what's happening to their bodies? What if we take these technologies and use it to train our surgical registrars better so they are better surgeons tomorrow? And whilst I started engaging in this and then undertaking this further as a PhD, I realized it is even more important to engage with this technology now, because whilst we're perfecting the current applications, we're also at the same time, in parallel, working on future applications of these technologies. And some of those applications has been alluded to in the previous talk, and by this I mean technology such as bioprinting, which gives us the ability in the future to say if a patient needed a bit of their body part resected because it was affected with disease, we were able to take a little bit of fat from their body, culture stem cells on it, and 3D print a new body part to replace that defect. I know this starts to sound a little bit like science fiction, but I'd like to demonstrate these with some practical examples of how they are effective. But to help me do that, I'd really like to introduce you to my co-presenters. Firstly, we have a pioneering head and neck surgeon, Professor Jonathan Clark, who is a professor at the University of Sydney and also the Director of Research and Fellowship at Lifehouse and RPA. We have the sheer genius of Professor Gordon Wallace, who has not only been awarded the Order of Australia this year, but he also won the New South Wales Scientist of the Year award earlier this week. He is the he's an executive director of the ARC Centre of Excellence for Electromaterials Science, and also the director of the Australian National Fabrication Facility Materials Node. Then we have the very creative Kai Cheng, who's our Surgical Innovations Research Officer at the RPA Institute of Academic Surgery, and also a PhD candidate with me at the University of Sydney. We have a Master of Innovations, Dr. Hamish McDougall, who's the Principal Research Fellow of the Garnet Pass and Rodney Williams Memorial Foundation, and also Senior Lecturer at the University of Sydney. Last but not least, we have Paris's best gift to us, Dr. Elodie Chiravano, who is a postdoctoral research fellow and also an associate lecturer at the University of Sydney. Before I go on, I'd really like to acknowledge the funding bodies that are helping this research be possible, and that's the Garnet Pass and Rodney Williams Memorial Foundation, the Sydney Local Health District, of course, and also the RPA Institute of Academic Surgery. So I'd like to start off with showing you some practical examples about how this technology works, but to do that, I'd really like you to follow me to the emergency department. So this is Rhydian. Rhydian is a fellow from Manchester who's training to be an ENT surgeon and is here doing a Masters of Surgery with us. Quite understandably, Rhydian is a very big fan of English soccer, and whilst watching a soccer match, in the heat of excitement, he was chewing on a pen lid and a critical goal was scored, and he feels that he's inhaled the tip of a pen lid. Or that's what he says to me, which is why his assignment's late. So I can't see anything on an X-ray, but I'm wondering, Kai, are there any tools we can use to visualize this better?
Yeah, I think we can use augmented reality to visualize patient's condition.
Okay, well, let's have a look then. So what I'm going to do is just use my phone and pop that on his chest and use my app that's on my phone to have a look. And indeed, if we just have a look at this image, we can see a 3D render through the phone of the lungs and the heart and some organs. And if we just get closer towards the root of the heart and the major vessel, there's our region of interest. There's the major airway called the trachea, and behind that is the food pipe called the esophagus. And let's track down to see what's going on in his airway. And oh, indeed, hang on, there is a lid of a pen. You were chewing on a blue pen lid, looks like, Rhydian. And one of the reasons, Kai, Rhydian is so stable at the moment is because that pen lid is actually not completely obstructing his airway. So he's breathing around it. So that is indeed very helpful to be able to see this in 3D. But being an ear surgeon these days, I haven't really done an airway for a while, so I'm just going to head over to Hamish's lab to see if he has some simulation for me. Thank you. See you in a bit. Dr. McDougall, how are you?
Thank you. How are you, Paya?
Wow, so I can see that you've got the model that that you and Kai have been working on of this case with a tumour in the nose. It looks fantastic. So just to explain to others what this is, we have a 17-year-old boy who's got a benign tumour in his nose that in the days of minimally invasive surgery, we plan to take out through his nostril without any cuts to his face. But it is quite large, and there's some critical anatomical dilemmas. Hamish, can you help me? Can you help describe the anatomy for me?
Certainly. Kai's made this extremely easy for me, not being medically trained, by marking the tumour in blue. And if I look up the nose, for example, and through the eye socket, I see evidence of the tumour almost everywhere. I can draw the margins and I can try and visualise how on earth a surgeon is going to try and get this out.
Yeah, well, one of the reasons we're taking it out is because the tumour is putting pressure on the eye, and if we don't take it out, then he'll go blind. Are there any other critical structures you can show me?
Certainly. If we rotate this around.
Wow, there's a lot of red blood vessels.
Indeed, I think this is the biggest trick here, is that the tumour is wrapped right around the carotid artery here. If I highlight that for you, that's going to be a tough job.
Yeah, and that is really the critical problem, because whilst we've got very little access, good vision but little access, if we are able to visualize these things beforehand and prepare for these things beforehand, then fatal complications such as having a carotid bleed in the back of the nose can be averted. So that's fantastic. It's very useful. Thanks, Hamish. But I actually come to you with the ulterior motive. I've got another student. If you remember, a few months ago, I had an Italian student with a pen lid in his airway. And you won't believe me, I've got another one, but this time an English one.
Oh, not again. Seriously?
Yep.
Have you considered just feeding them instead?
Feeding them? Next you're going to ask me to let them sleep. This is surgery. All right. Well, can I hook into your virtual theatre and have a look around and do some practice?
Please do. Jump in.
Thank you. Excellent. Wow. Do you want to walk me through your theatre?
Certainly. So this is a virtual operating theatre that we made at the School of Psychology at the university. We only invested about a day in building this, which sort of made me amazed. Since we've got lots of fun stuff, we've got, for example, the patient's vital signs here are animated in real time. We have a computer that we can use to make sure it's the right patient, which I'm told is always a good start. The microscope over here actually works, so if you hold a tissue sample underneath it, you can see a magnified view. We have all of the lights and the usual paraphernalia. We hung an X-ray here, which we thought was fun because it's transparent in all the right places. If I hold my instruments behind it, I can see through it.
And a mirror.
We even see each other. So
Yes,
not only do I
absolutely.
see your head and you see me and hands, we see each other in the mirror.
Great.
But most
And
important, and the
here's
thing
the
we should
patient.
focus on, is the patient, of course.
And I've got my virtual telescope, a virtual endoscope, I must say. So we're going down the airway, or the trachea, and there's something blue in here. You can tell that I've done this more than once. There's a blue pen lid that you've put in there for me.
Yes, we realise you're going to do this a lot.
That's fantastic. But the beauty of this is not just the fact that I can, I'm not limited to anatomical plane, so I can actually do an esophagoscopy if I wanted to. And I could even go into the chest and have a look at the lungs if I wanted to. And I'd bet I'd probably be able to see your instruments as well, wouldn't I?
Yes, indeed. If I bring my laparoscopic instruments in and try and find the end of your camera, there we are.
Brilliant. Do you think you could try and find the end of this pen?
That would be an interesting challenge. I like the idea of that. All right, I think I've got it. Excellent. So we've got him
fantastic.
out with the laparoscopic instruments.
That's great. So one of the other things is, we can sort of wander around the body. I'm sort of looking at the abdomen, but we don't have to do that with a telescope, do we? We can wander in and have a look for ourselves.
Indeed, this gets a bit personal with a real subject, but in virtual reality, I can put my head right inside his chest cavity. And for you, this looks kind of flat, two-dimensional, but it's fully 3D for me, and it really helps me understand the arrangement and geometry.
That's fantastic. So Hamish, you've been doing this for a while. Can you tell us about some of the advantages that you see of this technology for surgical training?
Sure. I think the thing that I'm most excited about with this demonstration is the fact that there are two of us collaborating in virtual reality. And it so happens that we're standing both here on the same stage, but there's no reason why we couldn't be 8,000 miles apart. There's nothing connecting our two computers except a low bandwidth internet connection. So you might be in America and I could be in Australia and you might be teaching me a particularly tricky surgical procedure.
I could be in Sydney and a colleague could be in Wagga, and we could be teaching each other surgery without needing to travel to each other.
Exactly. The
That's
telemedicine thing in Australia is
Absolutely.
always important.
What else? What other advantage do you see?
The huge advantage for us at the uni on fairly limited budgets, of course, is there's huge saving in cost. You know, everything that we're using today, you can buy at the local shopping centre for about $1,000, plus a fast PC, and that obviously is kind of insignificant compared with the millions you could spend on a real surgical simulator made of stainless steel and with all the appropriate instruments.
Fantastic. And I bet you could scale that too, couldn't you? Because you could just translate this to some other specialty or another use.
Yeah, I think that's the power of collaboration. If I were to send you this surgery by email, you could do a little bit of work on it and add some new gadgets or some new procedures, and then email it on to your colleagues, and you know, after a few rounds of that, we might get something looking really fancy.
This is fantastic. Thank you so much, Hamish. But I better get to work, so I'll see you in a bit.
Okay, good luck with it. Enjoy.
Thank you.
So my name is Jonathan Clark. I'm a head and neck reconstructive surgeon. You've already met Kai, who's our Surgical Innovation Research Officer. We're going to talk to you about using the fibula to reconstruct the jaw using virtual surgical planning. This lady's had a cancer of her jaw removed in China, and unfortunately, instead of replacing the bone, they've just used a plate. We need to work out what the underlying bone looks like. Kai, would you be able to use her CT data and show me what it looks like at the moment?
Sure. So here you can see I'm using an open source medical imaging processing software called 3D Slicer to segment and construct a 3D model from patient CT scan data.
Okay, this looks pretty bad, Kai. The bone's all twisted, it's in the wrong position. Would you be able to simulate what a normal jaw should look like?
Okay, so I have constructed a normal jaw in 3D for the patient and superimpose the normal jaw over patient's remaining jaw.
Right, I can work with that. Can you use your 3D printer to print that out for me?
Sure, no problem. So the 3D file will be sent to our 3D printer and get it ready for use.
I'm on a little bit of a tight schedule. Is this going to take very long?
It will only take about 2 hours to get the model ready for use. And I also print patient's remaining jaw and facial bones for planning and the testing purpose.
Okay, well that's really helpful. So here's the jawbone articulating with the skull. So the next step for us is to bend a new plate to match the exact contour of this ideal jawbone. So I've just drawn on there where I'd like the plate to sit, and I've sent down one of my team to bend a new plate. I think they've done a pretty good job.
Yeah, it looks good.
Not bad. So I'm going to need some guides to help me know where to cut the bone, but how do you make sure that these guides actually fit the contour of the bone precisely?
Yeah, actually it's a very challenging task, but I have figured out a solution. So here you can see I'm using surface model optimization technology to create the cutting guide. So by implementing this technique, I can ensure the inner side of the cutting guide will match patient's remaining jaw at the exactly spot as we planned. So this is a 3D printed model.
So that sounds good in theory, but how can we be sure this is going to work?
We can examine the 3D printed cutting guide by putting it on the 3D printed patient remaining jaw, so we can test it.
So the fibula is a straight bone, and I've just drawn on this bit of paper how I think we should cut that bone so that it's going to match the contour of the plate and the jaw. Would you be able to design some guides that'll help me cut the bone at exactly the right angle?
Yeah, no problem. The drawing articulates the measurement, cutting angle, and the volume for the fibula segments. So here you can see I'm using 3D Max 2016 to develop cutting guide for the fibula. And a holder is also being developed to hold all the segments aligned, to keep them aligned during the procedure.
How are we going to fix these guides to the bone?
You can see these holes, they are in 1.8 millimeter in diameter. So all these holes will be used to temporarily fix the cutting guide to patient fibula.
And what about if I need to change the plan during the surgery?
Yeah, I have prepared several options regarding the measurement and the cutting angle to adapt to the plan change.
Okay, so you're printing out the guides here for me now?
Yeah, this is a speed up video, so it's about 20 times faster than real speed.
So let's take it into the operating room and see how it works.
Okay.
So we're cutting the jaw there at the precise angle of the guide, and we're just checking these guides match the exact angles that we've calculated from the plate. And now we need to take the fibular bone and fix it to her jaw. I'm looking from the right-hand side, and that fits pretty well. Now we're going to look from the left. Look, it actually matches the plan precisely. Kai, I'm pretty pleased with this. The operation's taken a little over 8 hours, but I think we've actually saved about 4 hours of operating time.
That's great.
More importantly, we've achieved an outcome that I just don't think would have been possible from my expertise alone.
Thank you.
So the next step is we're going to make some teeth for her. I'm going to need your help with that,
Okay.
but just not today.
Wow, that was amazing, Jonathan. So can you tell us a little bit about the benefits that you see of this technology to the patient and the team?
So normally when we do jaw reconstructions, and we do a lot of these, we can use the jaw that's existing as a reference point. But for this sort of case, it's really difficult. There are no reference points there at all. And if I don't get the bone in the right location, then we're not going to have the teeth in the right spot, and then she's not going to be able to chew. It's going to affect her speech and her swallowing. It's going to have quite serious effects.
Wow. And so how much would something like this cost then?
Well, unfortunately, not all health services have got someone as talented as Kai at their disposal.
Yep.
So if I did this at another hospital, I can do this using industry, and that'll cost me about $10,000 per case. It's worth it, but if we have someone who's able to do this in our own institution, then really we're just talking about the materials, and that only costs a couple of $100.
Brilliant. Not to mention the collaboration that you get between the two. So we talked about cost. What about saving? How much does it save the health system?
Well, running an operating theatre is not cheap. It's at least $2,000 an hour. So if I'm able to save 4 hours, and it could be more in many cases, there's $8,000 straight up.
Not to mention salaries of, at least, 8 people in theatre at the same time for some of these cases, or
at least.
Or more, yep. And given that if you take one hospital, so RP alone would spend about $40 to $50 million just in operating theatre costs, and $200 million at least annually just on surgical services. If you scale that, it's quite a significant saving, isn't it?
Oh, it is, and this is really quite applicable to a number of other specialties. It's not just head and neck surgery.
Yeah, this is fantastic. And you know that I think this is amazing, don't you? Not to mention that I think most of these people, excuse the pun, have their jaws dropping right now.
I sense there's a but coming along here.
I think we can do better.
Better.
Better, yeah. I think you're working too hard. I think you're working too hard.
Yeah, I know I'm working too hard.
I think in the future we have access to technology where instead of doing all of the planning or even trying to get donor bone from the fibula, I think you can 3D print living bone in the shape of the defect that you want and just put it back in the patient. So all of these hours of planning would be saved, which is good for you.
Yeah, but that sounds great. I mean, I've heard about this sort of stuff, but nothing's going to be like using the patient's own bone.
I thought you might say that, but that's exactly what I'm saying. You get stem cells from the patient, you culture bone from that, you 3D print that so you can control the shape of the bone that you're growing in the lab. And I know you're looking at me funny, and exactly why I've invited Professor Gordon Wallace, who's a leading scientist in Australia and internationally, to help convince you and others that this is not science fiction.
Okay, let's hear it.
Welcome, Gordon. Congratulations, by the way, on the award that you've just been awarded.
Thank you.
So, Gordon, we've just been talking about 3D printing a lot. Can you tell us, just summarize what 3D printing is?
Yeah, so 3D printing enables us to build very complex structures layer by layer. So complex structures from a very simple technique. And it's so versatile that materials discovered literally today in our laboratory or somewhere around the world can be translated into a structure that we can apply for medical applications within a number of days.
Wow. And so what's bioprinting then?
So with bioprinting, there are several There are several approaches to bioprinting. One involves printing of metals that are implanted into patients
Yep.
to provide structural support.
Yep.
That could be a 3D printed hip or knee replacement, for example. But some of the really exciting things in bioprinting focus around trying to get the thing to work. Focus around 3D printing of living cells, and
Yep.
we've alluded to this already. So we've developed bioinks that can protect cells while they're in the reservoir, can protect them during the printing process, and then ensure their survival afterwards, and in fact control their development afterwards. So using inkjet printing, we can actually print cells with unicellular resolution. So you can put a nerve cell beside a muscle cell.
Yep.
You can start to create very complex structures with that 3D bioprinting. But there are some examples where we do require high densities of cells during printing. One of those is actually printing those adipose stem cells or fat stem cells
Yep.
that we print into a complex structure. But that structure is such that the chemistry and the mechanical properties of it
Yep.
ensure the efficient regeneration of cartilage.
Right, cartilage, Glad you mentioned cartilage, because about 18 months ago or so, we started off on this journey, didn't we, about trying to bioprint cartilage in the shape of the ear, not the ear. And the reason for this is to try and find a better solution to a condition called microtia. So microtia, for those who are not aware, is a condition where people are born with the malformation of the ear. It's a congenital malformation where the ear not only looks abnormal, but also patients can't hear. And because it looks abnormal, you can't wear a hearing aid on top. And currently treatment for that involves numerous surgeries, usually taking rib cartilage from children to reconstruct their ears, and is riddled with complications, which I can say because I'm not a plastic surgeon. And there is really a better solution required. And Gordon, can you please tell us how bioprinting has some hope for this
Sure.
condition?
So you've already heard how 3D printing can be used either to extract information from a model or from a scan in order to replicate shape. And so that's quite an easy task. Well, the challenge here is how do we actually replicate this very complex piece of this device here, with that mechanical property distribution and the living cells throughout it. So we're creating a 3D printer, a customized 3D printer, which first of all prints a structure, a supporting structure. The second head creates that distribution of mechanical properties in the ear, that distribution of stiffness. And then finally, another head actually prints gel-like materials containing those living cells, containing those patients' own stem cells.
Yep.
And we can create that structure so it looks like an ear, feels like an ear, and
Yep.
hopefully it's going to work like an ear. And at that stage, of course, we hand it over to you, where we've created all of that complexity within the ear.
Yep.
After implantation, those cells will continue to proliferate and differentiate into that cartilage that's required to really recreate a living ear.
Yep, absolutely. So, and we're in this critical stage of our research, aren't we, Gordon, that we need to bring this research from the laboratory at Wollongong into a clinical site. And in that, we're really grateful to our CEO, Theresa Anderson, for customizing this laboratory for us. So we're going to have the first bioprinting laboratory in a New South Wales hospital. And why is that so important, Gordon? Because, I mean, you imagine it's obviously going to help our project, but there's got to be translation to other clinicians as well. If you have basic science research at a clinical laboratory, other people can use. Is that what you found in your experience?
Yeah, definitely. So we've got an extensive clinical network around this country and indeed around the world, working on particular clinical challenges. And a lot of that has come about through our physical presence in the clinical environment. We created a 3D printing capability at St Vincent's Hospital in Melbourne, which has given rise to a number of projects, initially around 3D printed structures for the cochlear ear implant, for the bionic ear, looking at nerve and muscle regeneration, spinning off into 3D printing structures containing islet cells to treat diabetes. And then, of course, the one we mentioned before, the 3D printing of structures with those fat stem cells to regenerate cartilage. Now, that's been a particularly interesting one because it's not only involved development of the bioink, but the development of the delivery system. So this is a customized delivery system. It's a handheld 3D printer, so the surgeon can print directly into the defect during surgery to regenerate that cartilage. And we're finding lots of opportunities and challenges in developing these customized printers to satisfy that clinical network.
Yeah. So it seems like there's a lot of R&D happening in Victoria at this stage, and apart from the fact that we don't just want to catch up to the Victorians, but we want to beat them at it, can you tell me a little bit more about why it's really important as Australians we get seriously behind the development of this technology?
Yeah, sure. Look, there's plenty going on in New South Wales as well. So,
of course there is.
The work we're doing with yourself on the 3D printed ears, and also with Sydney Eye Bank, we're actually developing a refined version of that handheld printer to print directly into the eye for corneal regeneration.
Snoring.
And with Stuart Mackay in Wollongong,
Yep.
3D printed structures around understanding and treating sleep apnea. So
Yep.
yeah, it's exciting developments all around the country, and you know we're very lucky. Australia is incredibly well placed in this area.
Yep.
We are well placed to cover the whole pipeline from the sources of the biomaterials for the bioinks.
Yep.
We work with seaweed farmers, for example, in doing that, all the way through to designing the machinery and building that machinery,
Yep.
where we're working with those who no longer make components for the automotive industry but are building 3D printers
Wow.
for us. Right the way through to that clinical network and those clinical applications and delivering those packages. And one other thing that sets us aside is that we do, at the moment, lead the world in training in this area. With QUT, we've established global master's courses in biofabrication,
Yep.
and we have an ARC-funded training hub in
Yep.
biofabrication as well.
Yep, so you've sort of got the whole package here. So it's not just important for getting our patient outcomes better or training and education better, but also where if we really get behind this together collaboratively, we're sowing the seeds for future industry growth in Australia as well.
Yeah, and not just future industry. There's new industries being established this week, I can tell you, around the manufacturing of the biopen.
Wow.
We're signing agreements to manufacture those in Australia. We're building new entities with a seaweed farmer in order to harvest those important biomolecules from the seaweed to go into the bioinks. And of course, these clinical connections in the networks really help us to roll those technologies out into a clinical environment to the benefit of the patients as quickly as possible.
Well, I certainly hope that you've given Jonathan a jaw-dropping moment now. And I think this is amazing. It's truly inspirational. But I suppose for us on the front line of healthcare, we see these benefits in our patients, but there's a lot of people who don't get to see these benefits. So let's hear from our patients' point of view what they think about these technologies.
Very good.
Thanks, Gordon.
All started with a lump behind my ear. I actually had the surgery and I thought that was it. About a little over 11 months later, 3 more appeared. I had to have the whole parotid gland removed. If I hadn't had the surgery, it gave me approximately 2 years to live.
Well, I've a history of ear issues from a very young age, about 11 or 12, had operations. A disease that was very hard to explain. It was cholesteatoma. Effectively, the ear had been stable until a few years ago where I decided to try and reactivate the ear. So those new scans showed up a recurrence of the original cholesteatoma. And unfortunately for me, that meant that not only was the reactivation not possible, but major surgery was then required.
Horror would be a good word. Anxiety. I didn't know how I was going to turn out. I still didn't realise that I would live through it.
That process was then kind of a year of planning for the surgery and getting the family ready. They were difficult sort of time.
And then the most wonderful part was that she showed me the 3D imaging. She actually was able to show me exactly how they were going to take out the parotid gland, how she was going to come in and do all the bone work.
It was difficult to kind of get the conceptual, what's going on inside a skull. It's a very mysterious place. And so it's very difficult to explain, particularly to children, or in my case, older children. So the idea of the model then was, well, it's much more contained. It's specifically to me. I could get little bits of aluminium foil, crush them up into the shape of the disease and put it in the little cavity that it created. So I know my kids ran away and said that's gross, but by the time we got to the surgery, I understood what was going to occur, or I understood and my family understood, which which was very different, I think, from the initially, which was this sort of strange black cloud that appeared after 30 years and something had to be done.
The difference to me was that I knew what was going to happen to me. It was the first time that I could actually see what was going to happen. And the 3D imaging was just so incredible that you could see everything. Your ear canals, your eye sockets, even where your brain sat. It was just amazing. I just understood it. It was like a light coming on in the rain.
Before, if you said carotid artery and facial nerve and brain cavity, it just everything sounds a massive problem, which it probably is. But when you put it into a model and you can visualise the process of this growth, my information base was much stronger, so the confidence was stronger.
I think for patients going through what I did, it would be very important, because I think if they had more understanding of what's happening to them, they'll feel more empowered.
You're not just looking at it for fun. It's got some real purpose, and that's that was what was exciting about being involved in it, because it was relatively early. But seeing technologies used in a way that's kind of human, I wouldn't say I enjoyed going through that, but it was at least almost therapeutic to figure out exactly what was needed. So, and I still have one of them at home. So it's a trophy.
So as you can see, healthcare is moving into an era of patient-specific solutions, or customised healthcare. And in this space, using these innovations to achieve those goals is not only helping us achieve better outcomes, but it's also helping us reduce health costs at the same time. And in parallel, we're starting to sow the seeds of development of Australian industry where possible. But it is important to emphasise that none of this research would be possible without the support and encouragement and funding that we get from institutions such as the Ghana Past, from the Sydney Local Health District, and the RP Institute of Academic Surgery, because it's not possible for us otherwise, us as clinicians, when we face a problem that a patient presents with, take that problem, put our innovative juices to work in our teams, and come up with what my patient Mark Prattley put as a purposeful innovation. However, even though this technology is around us everywhere and every day, most hospitals in New South Wales don't have access to this technology, and that is not good enough. That needs to change. And we can only do that by teamwork. And I don't just mean the sort of teamwork that you've seen up here with scientists and surgeons working together. I mean a global team. We need to work across healthcare involving regulators, health economists, administrators, and of course the ministry. So hopefully, I've tried to give some examples to show that this technology is here today, it's here to stay, and we need to engage with it now. So thank you very much for letting us share our research with you, and I'd really like to invite my co-presenters back on stage, and very happy for any questions that you may have.